Radiographic landmarks and lines that we'll be using to position the patient are the orbital meatal line, the infraorbital meatal line, not so much the glabellomeatal line. You may hear it referred to, but we don't use it much. The interpupillary line, the acanthomeatal line, and the mentomeatal line. So the orbital meatal line would be just that. It's a line that runs from the outer canthus of the eye to the EAM. Infraorbital meatal line would be from the bottom of the eye out to the EAM. The glabellomeatal line, obviously, from the glabella out to the EAM. The interpupillary line is a line that runs between the pupils. The acanthomeatal line goes from the acanthion out to the EAM, and then the mentomeatal line goes from the peak of the chin, which is the mental point, out to the EAM. So mentomeatal line, acanthomeatal line, infraorbital meatal line is here. The orbital meatal line, which is also referred to as the radiographic baseline, because that's the line that we use most of the time for positioning. The glabellomeatal line, and then we looked previously at the interpupillary line here, going in between the pupils. So, two that you need to be aware of alternate terminology for. One is that radiographic baseline being the orbital meatal line, but because the size and the structure of children's head, their head is so much different than adult heads, the baseline for children is a different baseline. So the acanthomeatal line is going to be the radiographic baseline in children. So skull morphology, we talked about different shapes of the skull, but because of the different shapes, we may have to adjust our central ray in order to compensate for different skull types. What we're going to talk about and what you'll be tested on all the way through the registry are angulations and positioning for mesocephalic skulls, so average skulls. You need to consider body position. Patient may be examined upright or recumbent, either one, but consider their history. If they've fallen because they got dizzy and they fell down, it's probably not a good idea to stand them up. If they come to you already on a stretcher, it's probably a good idea to go ahead and take the images with the patient laying down. Certainly if the patient is on a backboard, you don't want to move them off of the backboard to do skull views unless they've been completely cleared of the backboard, in which case they should not come to you on a backboard. If you have the option and if the patient is stable enough, it may be better to shoot the patient upright than what it is to have a patient on the table, and we'll talk about that here in just a second, because their body position can affect how easily you can achieve true anatomical positions or radiographic positions using the baselines and whatnot. So consider these two. You got a patient here, he's probably sthenic, maybe a little on the larger sthenic side. I don't know, I can't see his gut. But consider if he was hypersthenic, if he was really big, thick hypersthenic, he has a great big belly and a great big chest, then what you might have is a situation where his head cannot get into a good lateral position like this. So where the interpupillary line applies in a lateral is that you want the interpupillary line to be perpendicular and perpendicular to the image receptor and perfectly vertical. So if a patient has this great big barrel chest and a great big fat belly and his head is at a tilt, then what that's going to do is put his interpupillary line at an angle like that. But if he's upright, then he can put all that tissue up under the bucky and he doesn't have that same positioning error. But again, if a patient has a history of falls because they got dizzy, it's probably not a good idea to have him upright unless maybe you put him in a chair with a back and arms on it. but certainly don't stand him up. So consider, triage your patient and figure out, what the best position for the patient would be based on their history. So if you have a patient who is hypersthenic or asthenic, you may need to support something in order to get them into the positions that you want them to be in. So back to the position here, the picture here. If you had a hypersthenic patient, what you might have to do in order to get that interpupillary line perpendicular to get a true lateral position is you may have to elevate the patient's head. You may have to build his head up, put it on something, and of course that's going to increase your OID, which increases magnification, decreases sharpness or recorded detail. But that loss of sharpness or recorded detail is probably better. That increase in OID is probably better than the mispositioning of having the patient at an angle, and therefore any possible pathology may be projected into the wrong place. So consider the patient's body habitus, and if you have a patient who you have to lay down and you can't position well, consider building up the patient and putting them into a position that may be a little bit better for their anatomy. Likewise, if you had an asthenic patient, then what you might have is a situation where instead of your interpupillary line going this way, then a very thin chest with a relatively large head may cause the patient's interpupillary line to be off and tilted in that direction, in which case you may have to build up the patient's chest. I think there's some diagrams in the textbook that show that. If they're not, they are right here. So you have a hyposthenic or an asthenic patient, you may have to build up their chest. Or you may have a hypersthenic patient, you may have to build up their head. Make sure, obviously, that you've got a radiolucent thing to put the patient's head on, a sponge or whatever. So cleanliness. Hair, skin, face, lips, mouth, nose are especially oily. And people know that. And some of the projections that we're going to use, some of the positioning that we're going to use, we're going to put the patient's mouth directly in contact with the image receptor. So some of the projections that we're going to utilize, you use the acanthomeatal line and you put that perpendicular to the image receptor. So their mouth is millimeters away from the image receptor at best. So a couple of things. One is that you want whatever you're putting the patient's face or head up against to be clean. So you should be in the habit right now of wiping down your image receptor and wiping down your bucky and your tabletop in between every patient. If you're not in that habit, you need to get in that habit. So that's number one. Number two is that even if you wiped it after the last patient, wipe it again, but wipe it in front of this patient. If you're going to ask me to put my face on a wall bucky, I'm going to want to know that it's clean, and I'm not going to want to assume that you did your job after the last patient. I want to see it happen. So clean it, and clean it in front of the patient so that they know that they're putting their most intimate anatomy onto a clean surface. So wash your hands, make sure that you got your gloves on, if that's hospital protocol, and make sure that the equipment is clean as well. Radiation protection, for the most part, is going to be your collimation, but we do have some positioning that we're going to use, specific positioning to reduce radiation dose to the eyes. Also, it's a good idea to put a lead apron on a patient if it's not going to interfere with the exam. So make sure you lead up the patient. Remove any kind of artifacts, so eyeglasses, obviously, dentures need to come out, hearing aids need to come out, any kind of jewelry, Hair pieces, any kind of wigs need to come off, hairpins, barrettes, ponytail holders, prosthetic eyes if the patient has glass eye. That's going to show up very boldly on the image. Our essential projections of the skull we're going to use over and over again throughout the semester. We'll see lateral in multiple exam groups that we'll test on. It's going to be used in some way in pretty much everything that we do, skulls, facial bones, sinuses, and so forth. We're going to use PA over and over again. PA, we'll use PA axial, which is also referred to as the general survey view, which is just PA positioning with caudal angulation. AP axial is a reverse of PA axial, and sometimes it's referred to as reverse Caldwell. So AP is just reverse of the AP, or the PA rather. The AP axial is a Town method, and it's a different axial with the central ray angulation of a different magnitude in the opposite direction. The Haas is the reverse of the Towns, and it is a PA axial projection as opposed to AP axial. And then SMV we're going to use over and over again. So the views that we're going to see over and over again are lateral, positioning for the PA, might utilize the central ray angulation, but there are a couple of different variations of the Caldwell that we're going to use. If you can't shoot PA, we're going to use AP. AP axial if we can't shoot a PA axial for Caldwell method. The AP Towns, if we can't shoot AP the Towns, or AP Towns, AP axial Towns, then we'll use a PA axial Haas. And a SMV, we're going to shoot, we're going to see that in pretty much every exam group that we talk about this semester. So instead of jumping into the projections, what I'm going to do is I'm going to skip forward. We're going to take a look at some x-rays and some fractures and things that we might shoot skulls for. To be completely honest with you, skulls have gone to CT, so we don't see a whole lot of actual skull work for trauma in diagnostic radiology, as they should, because so much can be going on inside of the patient's skull that we just cannot see. I don't mean inside of the skull as in skull fractures themselves, but rather inside of the cranium. The damage to the skull is really irrelevant. If the patient has a skull fracture, whether the skull fracture is present or not, the damage inside of the skull can be significant enough that regardless of what's going on with the bones themselves, the patient just may not get past the injury. So we've got fractures, and fractures can be of a number of different types. This is an unusual fracture. It looks like it fractured right along that lambdoidal suture. Most of your skull fractures are of a number of different types. You may have a linear fracture, which I think that's what this is attempting to show here. You may have what they call a stellate fracture. And a stellate fracture occurs, and it's got, you got maybe a one impact area, and then you've got a number of different lines leading out away from it. A very common fracture would be what they call a depressed fracture, and a depressed fracture is where you've got a number of different fracture lines, and you've got a mashing in of the bone. So you got a little compression going on there. All right, so because it's very difficult to make out any kind of fractures, in a lot of cases patients are going to go to CT. And again, you can't tell what's going on underneath. This is a depressed fracture on a child. This is a child's skull, and you can kind of see it. The features are exaggerated. So that's how you know it's a child's skull. But you got a depressed fracture there. We've got other issues that we may have with the patient. We've had a situation here locally, actually, many years ago, where a patient actually got stabbed in the skull, and the patient was dead on arrival, but the knife was still inside of the skull like that. Gunshot wounds. I don't know exactly what happened to this guy, but you can see the base of his, or the apex of his orbit is just completely destroyed. I don't know if that was a gunshot wound to the eye. Multiple myeloma is what you're looking at there. So what you've got in multiple myeloma, and sometimes this is one thing that we might actually do a skull for, and it would be in like a metastatic survey. But what you see is a lot of odd densities that look like individual little cancers.